Hello guys, can you see me and hear me? If yes, let's start. I hope I'm audible and visible. So today we are going to continue wherever we left yesterday. We did see quite a bit about few cancer syndromes. We're going to continue, and today we might be learning few interesting things. One of the things is my favorite, von Hippel-Lindau syndrome, and it has been extended a little bit with the recent understanding of von Hippel-Lindau syndrome. And there's actually a new group of syndrome. FAP has a newer name now. It's called as brain tumor syndrome. Right. So there are two things in brain tumor syndrome. One is FAP and one is Li-Fraumeni syndrome. And obviously the famous Li-Fraumeni syndrome we'll going to look at, and few other like Gorlin and your Basal's and newer Basal carcinoma syndrome also we'll have a look at it. Right. So that's what we're going to do today. Same thing. I might ask you a few questions here and there. If you are aware of it, do answer. This we'll learn together. Fine. Okay, start with, if you're a plus subscriber of Unacademy, you'll have all these options available for you. The notes have been corrected, it's been proofreaded, so it will be out soon in some time. Fine, it will be available for all the plus subscribers, and if you want the benefit of both Unacademy and Top Ladder, you can go with that. And I did have a student yesterday who raised the hand in the plus class, and I really felt it is a good one. Right, so if you're a plus subscriber, you can utilize this option. So because in a live class you might be a bit hesitant to ask a question in a face-to-face. The advantage here is you can ask the question, you can explain whatever you feel, and answering was a pleasure. Right, so all these special class features, it might help you in attending whenever you have free time, and it's going to be free of course. And there will be a plus special class today at 9 p.m. where we're discussing a mixed bag of MCQs, clinical scenario based and from own archives. So let's learn through it as well. Right? Okay, you can subscribe to anything, and if you don't have any code, you can use PathoCups. So coming back to the same slide, what I started with yesterday, we are done with this, we are done with this, we are done with this, and we are done with this. Right? So I'll try to do the rest of it today. Hopefully we'll be able to finish it. Fine. So shall we start? Okay. So what we are going to do here is, as I said, that we are going to look at all these syndromes in a different perspective. The one thing I want you to learn from every syndrome is, every syndrome has its own diagnostic protocols, right? I need these to be present to call it this syndrome, right? That's one thing which we are going to be concentrating on, and the other thing which you're going to be concentrating on is obviously your pathogenesis, right? So I'm sure you must have heard about von Hippel-Lindau syndrome, right? What do you think the gene mutated in von Hippel-Lindau syndrome? The location of the gene, it's VHL gene, obviously. The location is in third chromosome, right? The first thing we're going to go with VHL. Again, it's in VHL is a tumor suppressor gene. So what do you think will be the inheritance pattern? The inheritance pattern is going to be, good morning Avnash, inheritance pattern is going to be autosomal dominant, like any other tumor suppressor gene, right? I have an autosomal dominant inheritance pattern, and here I have something which is going to be in 3p chromosome. The gene is von Hippel-Lindau gene, right? Good morning Nishant. So what we already know about von Hippel-Lindau is, von Hippel-Lindau has one function which is going to help in your suppression of your it has some role to do with your hypoxia inducible factor. I'll tell first the normal function of von Hippel-Lindau syndrome, von Hippel-Lindau gene product, then we'll look what will happen when it's going to get mutated, right? So when you have a normal von Hippel-Lindau, what they will do is, I'm sure you must have heard about hypoxia inducible factor, HIF. It has a control on HIF, hypoxia inducible factor. It'll actually have a negative feedback on HIF. So what actually von Hippel-Lindau does is, the gene product, if the gene product is going to do, it's going to destroy hypoxia inducible factor, right? So it's like a feedback mechanism. Let's assume that one of us is having some episode of hypoxia. Obviously in response to hypoxia, I will have VEGF produced, everything produced, right? Just to counteract the hypoxia, like a hypoxia or anemic hypoxia. So what this factor does is, once the stimulus of hypoxia is gone, this factor should not be present, right? Otherwise I'll have persistent VEGF activation, so this factor should not be present. So von Hippel-Lindau syndrome is a negative feedback to hypoxia, right? So it destroys my hypoxia inducible factor, so in response to any hypoxia. That's one function. The other function of von Hippel-Lindau factor is, there's a new function which has been added. I hope if it comes in MCQ it might help you. It helps in cell cycle exit. See, we have learnt lots and lots of things about cell cycle transition, like transition point, G1 to S transition, G2M transition. There's something called cell cycle exit. So what we thought was, see, just tell me if I'm right in calling this. I have a cell which came to G1, which went to S, which went to G2, which went to M. This is the normal sequence of a cell cycle, right? So is there any possibility if a cell decides that, okay, I don't want to divide into mitotic division, can they exit cell cycle? We never had this approach till now. We always said that when a cell enters cell cycle, it will divide. It's not always the scenario, because if I'm going to enter my cell cycle, I'm not having enough nutrients, I'm not able to divide, they have to exit cell cycle also. One of the things which has been diagnosed or understood about exit of cell cycle is von Hippel-Lindau. This helps in, from G2 phase, it can exit the cell cycle and go into G0 phase, which is quiescent phase. I came to G2, I had all the material done for me, but I cannot divide. There's some problem, so I'll exit the cell cycle and remain in G2, right? For this, again, von Hippel-Lindau helps. These are the normal functions of von Hippel-Lindau, right? For us to know abnormal, we have to know normal, right? So once we know abnormal, as I said, that von Hippel-Lindau is tumor suppressor gene, because it helps in the exit, which means it's suppressing my division, cell division, so it has to be in tumor suppressor gene, right? So if I'm going to have a mutation in tumor suppressor gene, it should be gain of function mutation or loss of function mutation, which we have a fair enough basic idea. Every tumor suppressor gene will have a loss of function mutation, right? So here also I'm going to have a loss of function mutation only. So let's go, I'm just going to the side. Let's assume what will happen when I'm having a VHL mutation. See, VHL mutation is going to be a loss of function mutation. Fine. So it's a loss of function mutation. Two things are going to be gone for us. One is obviously there'll be no control on hypoxia inducible factor. So listen carefully and answer. If I don't have the control on hypoxia inducible factor, the amount of HI will elevate or reduce. It will obviously elevate, right? So the normal role is to inhibit HIF. So now the inhibition is gone. So double negative. So there'll be an elevated amount of hypoxia inducible factor. We'll keep this in mind. Whenever hypoxia inducible factor gets elevated, obviously the downstream pathway like VEGF will be elevated. Your beta subunit of fibroblast growth factor will be elevated, because these are angiogenic mediators, right? This will be elevated in response to the mutation. Other thing is, the cell cycle exit will not happen. The cell will not be able to exit, which means the cell obviously will divide. This will give proliferation of the cell. This will start the tumor formation. Okay, this will start the tumor formation first of all, fine? Sorry. So if I know this, now let's look at this part and see what's going to happen. So I'm just going to give you a scenario. We are just going to imagine and we will try to give reason for almost whatever features we are going to find in VHL, fine? It might be a little bit overwhelming, but yes, it's required for us. If you understand this pathogenesis, you need not memorize the criteria like we did for tuberous sclerosis, right? So when my hypoxia inducible factor is reduced, I'm right in saying that any time when my body has hypoxia, it's going to do only two things. One is increase my blood vessels, obviously, right? Other one is to counteract my anemia, increase my erythropoietin. That's what this also does. When I have both of them, you'll have elevated erythropoietin also, right? These two are going to take care of my blood vessels. I'm writing BV for blood vessels. This takes care of my RBC, right? So which organ in my body secretes erythropoietin? If I might know, definitely the organ which secretes erythropoietin is going to be a kidney, right? In adults, it's going to be kidney. So kidney secretes loss of erythropoietin. So am I right in saying that in this patient, the kidney is functioning too much than normal? Because I should have, this is a mutation, right? It's permanent elevation of erythropoietin. So definitely renal organs is going to stimulate more, right? So when I'm saying kidney is going to function more, am I also right in saying that kidney will get more blood supply? Obviously, right? So yeah, so when a kidney gets me more blood supply, I'm also right in saying that. I'll come to that, Avinash. That's a good hint for me. It's actually the peritubular cells. When kidney gets more blood supply, actually who gets most blood supply here is the peritubular cells or the tubules. Most likely the proximal convoluted tubules, right? We'll go to that soon, fine? So we'll just take this and I'm going to apply to kidney, because we know that erythropoietin is going to be supplied by kidney, right? So first, when I take kidney, there's a need to produce more erythropoietin. So there is more work required for sure. When there's more work required for sure, what is going to happen is, to my proximal convoluted tubule, it's not actually the one which secretes it, but in that area, I am going to have more blood supply, right? We'll have more amount of blood supply. This is a physiological response, right? Any organ which supplies more, you definitely will have more amount of blood supply to that organ, right? But here, I'm having a mutation. Am I right in saying that this mutation will increase more new blood vessels also to the place? Yes, because you have increased VEGF, increased beta subunit fibroblast growth factor. It's not only the amount of supply, there'll be increase in the vessel formation as well. Right? There's an increase in vessel formation. I'm having more blood supply. I'm right in saying that this cell in and around the PCT, I'm having lots of blood supply there, lots of nutrition coming there. So definitely they will try to go into a cell cycle, because more nutrition, anyone is going to say, okay, I'm going to divide, that's all. So, but here, is there a need for cell division? When all this happens, definitely there will be increase in my supply, the growth factors, all of them. So the cells will enter cell cycle. But I don't have an requirements for cell division, right? I don't have a requirement of cell division here unless there's a death. But once they enter, my body will understand that, see here, I don't want a cell division, I have to exit outside. What happens is, the exit is stopped here. So because of the increased nutrition, I enter into the cell cycle. Unfortunately, I cannot get outside because VHL is lost here in this patient. So what happens is, I'm going to have an increase in proliferation. Okay, I have increased proliferation. Since I cannot exit, I'm going to have a tumor. So I understood that why I'm having a tumor in my kidney, that too in my proximal convoluted tubule, because they are in the peritubular cells. That's the, place where I'm going to have lots of blood supply, right? So this is what happens. So I'm having one thing, I know the origin of the tumor. It's proximal convoluted tubule is the origin of the tumor. It's in the field of more vascularity, so that proliferates more, fine. Because PCT has the maximum capacity, one of the cells with maximum capacity to regenerate in my kidney, fine. So let's assume that I'm having a tumor which is arising from proximal convoluted tubule. I'm just going to extrapolate a little bit more for us to understand the beauty of the microscopy, right? So when I know this, I'm going to have increase in my PCT cells. At the same time, I'm going to have lots and lots and lots of new vessels. All the new vessels formed in my body will be only capillaries, right? An increase in amount of capillaries, right? There's a problem for me. Fine, there are two things that going to happen here. Both of them is going to determine how my microscopy is going to look like, right? Listen carefully. If you are not understanding at any point of time, ask me, I'll reply again, right? Because it's required for you to understand how the beauty of the microscopy, fine? So I told you just now that I'll have an increase in supply in the sense nutrition, right? In any part of my body, the nutrition is stored in the form of what? They are stored as glucose or something else. They'll be stored as glycogen, right? So I'm right in saying that these cells which proliferate will have lots of storage energy component, which is glycogen, right? One thing I already have, these cells will have increased amount of glycogen. Not only that, the second thing is I'm having abundance of capillaries. See, we are going to go back to my embryology. You must have read in embryology, the first starting page of Langerhans says that an organ is decided by the vascularity. Like when I want to form a liver, I need the vascularity, I need the sinusoids to form first. Based on the sinusoids, I'll form liver. That's how every organ is based on, right? The density of the capillaries, the density of the blood vessels, like if it's a big vessel, my body will automatically synthesize that, okay, this is having a large vessel, I have to form endocardium heart. It's everything the vascular network. Vascular network is very, very, very important for me to synthesize an organ or a tissue, right? So I have abundant density of capillaries. My body rethinks that, saying that, okay, this is looking like an adipose tissue. Because by birth, I know that whenever I have lots of capillaries, I have to synthesize adipose tissue. So what happens is, there will be increase in synthesis of adipose tissue as well, fat, right? So this both happen because of my pathogenesis. And this happen in my proximal convoluted tubule cells. I'm having more of fat synthesis in my proximal convoluted tubule, plus I'm having more of glycogen inside my proximal convoluted tubule. Both of them in microscopy. What is the color of fat in microscopy? I'm sure you know that. The color of fat in microscopy. Fat as well as glycogen, most of them have the clear appearance, right? So both of them in microscopy will be clear, right? They'll be clear. That's the reason we named them as clear cell carcinoma of kidney, right? The microscopic appearance is just due to the pathogenesis, that's all. I'm going to call it a clear cell carcinoma of kidney. The person who first saw it was lucky to call it a clear cell carcinoma. That time we didn't know the pathogenesis. Now we know the pathogenesis. I can extrapolate it is due to my VHL. See, it's not only clear cell carcinoma of kidney. If you know clear cell carcinoma of kidney, I know it's predominantly because of adipose tissue. So can I say how it will look in gross for me? The imaging in the gross finding? Yes, I can, right? The imaging of the gross, so in the gross finding, it's going to be yellow. Anything fat rich will be yellow in color, right? So microscopy, I know the appearance. Gross also I know the appearance. It's going to be yellowish color plus lots of hemorrhage. It's not just yellow, I'm going to have lots of hemorrhage there. Because more blood vessels, more capillaries, newly formed blood vessels will definitely be decay. I'm going to have lots of blood vessels with yellowish tumor. That's called as a variegated appearance. Robbins described them as variegated appearance, right? So I know one thing here. I'm not going to stop with the one. So this is the basic pathogenesis. The basic pathogenesis for every VHL related thing is this, right? Increase in VEGF and the cell cycle exit. So in other words, I am right in saying that this patient will have more blood vessel than any normal person, like more than you and me. The synthesis of blood vessel is more in this patient because of more VEGF. Let's say that in an organ, normally let's say that only 5 vessels comes, but in the same organ there are 500 vessels coming now. So when I'm going to proliferate at such an high rate, is there a possibility of having a tumor in the blood vessel? Definitely there's a possibility. Right? I'm having a possibility of tumor in the blood vessels. So tell me now, which organs in my body will there be more blood vessels here? This is again in response to hypoxia, right? I will not form blood vessels in the skin here because skin will not be affected by hypoxia. In other words, any organ which is very, very sensitive to hypoxia will have more amount of blood vessel formation. Yes? If that's true, then tell me which organs will have vascular tumors. The sensitive organs to hypoxia comes to mind is CNS, brain, right? Second thing, I'm just going to extrapolate one. This is my first finding, one of the criteria of your VHL. The second finding is I'm going to have increase in blood vessel formation in any organ which is sensitive to hypoxia, right? So when I say sensitive to hypoxia, I'm going to say my first thing which comes to my mind is CNS, nervous system. So in nervous system, I'm going to consider 2 places in nervous system, right? Perfect. One is obviously the brain. I'm also right in saying that my retina is also full of blood vessels, right? The second thing is my retina. Right? So the retina is also full of my neural tissue. So they are also very, very sensitive to hypoxia. So what happens is in these 2 places, I'm going to have more blood vessel formation, right? So I'm going to have more blood vessel tumor, that's all. So now we are going to say what type of blood vessel tumor I will have. See, we know that VEGF has started, is more, so there is more formation of blood vessels, many blood vessel formation. So the error in a blood vessel formation will happen when the cells divide, when the cells start to divide, right? An immature vessel, not in the immature, most vessels, it will be that more immature vessels. So I have more immature blood vessel tumor. So I call anything immature, like the best example, what is the most immature cell in a WBC lineage? We use the term blast, right? Blast is immature. So I'm going to have blastoid tumors, that's an immature tumor in my vessel formation. So I'm going to have, in both of them, I'll have hemangioblastomas. Okay, it's a blastoma, but it's again blood vessel form tumor. So it will not be microscopic small round vessel tumor, that's an exception. You'll have vessels and stroma. So how will I see hemangioblastomas? I'll have 2 components here. I'll have vessels formation. These vessels will be immature. Since a vessel is immature, it's not perfectly lined by the 3 layers, so I'll have hemorrhage. There will be lots of hemorrhage in the tumor, and I'll have stroma as well. Both of them are required for me. I'm having both vessel formation as well as stroma, and both of them are there in both retina as well as brain. I'm going to call it, that's my second and the third criteria. I can have retinal vascular tumors, I can have hemangiomas also, hemangioblastomas also. Second and third criteria, right? We come to the fourth criteria. And you look at liver, lungs, and spleen. See, these organs are already rich in vascular supply, yes. They have lots of vessels already, very rich in capillaries and sinusoids. So here, I don't have enough space for me to produce a new blood vessel. But unfortunately, I need to increase the blood supply for these organs also, because my body is having hypoxia. That's what my molecular thing says, right? So what happens here is, there will be increase in the caliber of the vessel. When the caliber of vessel increases, again throughout life, I will have bigger caliber blood tumors, which I'm going to call them cavernous hemangiomas, right? There are multiple cavernous hemangiomas in all these organs, right? So I'm just kind of filling all the criteria for me. There are multiple cavernous hemangiomas here, right? Then fifth. So there is more vascularity for sure, definitely. There's definitely, when there's vascularity there'll be more glucose and glycogen components reaching that target organ, right? So I'm right in saying that there will be undoubtedly more metabolism happening in this patient, in your brain, in kidney, in liver, lung, pancreas, everywhere. Yes. So if there is more metabolism happening, am I right in saying that I need more insulin? Undoubtedly I need more insulin or glucagon, whatever it is. I need more hormones, right? Pancreatic hormones. So in all these conditions, there is a high energy state in almost all the target organs. The target organs, what I mean to say is the renal, the brain, the CNS, everything, right? Retina, everything. There's more high energy, more target, so I obviously need more endocrine hormones. When I have more pancreatic endocrine hormones, so I'm right in saying that the pancreatic endocrine region is at high proliferation here because they have to match the demand. So there's a possibility of having a pancreatic neuroendocrine tumor. Can be an insulinoma, can be glucuronoma, whatever it is. But I can have neuroendocrine tumors in pancreas, like any, which can come from any cell, right? That's also one of the criteria seen in your one Hippel-Lindau syndrome, right? I can have neuroendocrine tumors in pancreas, right? Sixth. So we took care of the high energy state, but still the vessels are more. Undoubtedly the vessels are more. Like I said, that it will be at least 10 to 15 times more than a normal average human being. So the blood vessels are more. There is definitely a thing which controls my blood vessels. Like if you sat in your viva, your fingertips, your nose tips, your ear tips will become cold, right? What is the reason for that? The flight and the fright hormone, catecholamines. So whenever catecholamines is released, I'll have constriction of the periphery. I'll have constriction of the tiny capillaries. So this patient, if they have to have any stress in their life, the catecholamines should be produced more. Again, since there are 10 times blood vessels, I need 10 or 15 times more catecholamines, right? So when I have this catecholamines, am I right in saying that this patient's adrenal medulla is at more risk of proliferation because they want more? Yes, they want more. Since there's increased number of blood vessels, if at all I need a stress, there should be an increased amount of catecholamine production, and this happens throughout life from birth, right? So there's increased amount of catecholamine excess, there's an increased load on adrenal medulla to proliferate. When I have increased load on adrenal medulla to proliferate, I will have pheochromocytomas. So I'll have pheochromocytomas for sure. Fine, this is also a criteria, right? So we talked about 6 of the criteria. Everything with the pathogenesis of VHL being a tumor suppressor gene suppresses my hypoxia inducible factor and helps in cell cycle exit, right? You have to try to read the syndromes like this. See, almost every syndrome can be explained like this. The only thing is, it took almost half an hour for me for explaining one syndrome. It requires lots and lots of time. I can explain the tuberous sclerosis also, everything like this, but it will take lots of time, right? So when you go to a post-graduation, I just want you to look at this. Go and read a lot. You will try to give answers to everything. See, once I know the answer, I know that what I'm going to do in future. Like, I have to target and save the patient. That's my main goal, right? So if I have to target the patient, can I give an VEGF inhibitor in these patients? Will that reduce the will that reduce the tumors? We know about VEGF inhibitors, bevacizumab. Can we give bevacizumab? Obviously, I can give bevacizumab, right? Bevacizumab will definitely reduce the risk of tumors here. That's one of the trials there. So let's say that I'm having a patient who is having a risk of VHL, which is an autosomal dominant syndrome. So definitely the kids will be at a risk. So I need to evaluate these patients, right? So what I'm going to do is, okay, I have a risk of pancreatic tumor, renal tumor, adrenal tumor. An abdomen USG should be done, or an abdomen MRI should be done as a part of my review protocol. CNS, hemangioblastomas are common. I need to evaluate that. Retinal tumors are common. I need to do a fundoscopy, fundus examination, right? So all these will be in my how do I screen patients of von Hippel-Lindau syndrome, right? So if you know pathogenesis, I can make up every protocols based on the pathogenesis, so you won't forget the protocols. That's the only reason we took time to understand about von Hippel-Lindau syndrome. Fine. So not only that, von Hippel-Lindau syndrome actually is subtypes. We must have not read about the subtypes before, and I just want you to read about subtypes because we know about the pathogenesis. Because when you know the subtypes, that's the reason which comes that clinical diagnosis is not always enough for me. Because I have a subtype type 1, type 2A, 2B and 2C. This will be given only by genetic analysis. Because few of them will have risk only for RCC. Few of them only for pheochromocytomas. So I need not evaluate everyone for everything. So I know whom I should evaluate for, right? So I have something called as type 1 von Hippel-Lindau syndrome. It's characterized by hemangioblastomas and RCC. They won't have pheochromocytomas because of the mutation. These are caused by deletions and truncating mutations, right? Deletions in von Hippel-Lindau syndrome and truncating mutations. Say this, the pathologist will give you the thing, what subtype it is. Just do a genetic analysis of von Hippel-Lindau syndrome. It's my duty to say that it's type 1, 2A, 2B or 2C. Here there is more risk of hemangioblastomas and RCC, right? So I have in type 2, I have 2A, 2B and 2C. So in type 2A, it has the risk of again hemangioblastomas and pheochromocytomas and not RCC. This is caused by missense mutation. When you have missense mutations, this will have more risk of hemangioblastomas and RCC. Sorry, and your pheochromocytomas. No risk of RCC. We are still trying to understand them because the only reason why I need to know this is I might able to target what I want to look after, right? Okay. So type 2B, right? This will have almost the entire spectrum. I can have hemangioblastomas, I can have RCCs, I can have your pheochromocytomas also. So like type 2B is like the worst thing for me, right? I'm having every spectrum, might have a bad prognosis. Type 2C is good for me because here there's primarily an increase of pheochromocytoma. Hemangioblastomas will not happen, RCC will not happen, right? What happens here is there is a mutation again which is not going to detach my my hypoxia-inducible factor. It just it has a totally different approach which we'll read when you come to your post-graduation, right? Here only pheochromocytoma risk and there is no increase risk, means it's like a general population. No increase in risk for your hemangioblastomas and RCC. So this is good for me. I don't want to, if I'm going to have a patient who's in type C, right, I don't want to do an MRA for the patient. Brain MRI I need to do. I can take care of the abdomen alone because pheochromocytoma is the problem. Again, I don't want to go for an MRA. I'm suspecting pheochromocytoma. I can suspect that with a simple blood pressure. Tell the patient that, see, you have a splitting headache, blood pressure, palpitation, all of these are features, come to me immediately. Or if you want to evaluate the patient, you do a urine metanephrin. I can know, if I know what I'm dealing with, I can easily guide the patient, see this might be your problem, evaluate for that. I can reduce the expenditure, I can reduce the headache for the patient, it will be good for the patient management, right? So it's not always a clinical diagnosis. We are going to a place where it's having a transition towards the laboratory medicine, right? There is lots of transition happening because clinically I can suspect few things. Since we are in the evidence-based era, everyone is going to ask for evidence. When I go for genetic evidence, it makes my approach and the prognosis very perfect. That's the reason we need to know about these. So if at all anything comes in future, you might be able to answer based on that. Fine, great. So since we have done everything about my von Hippel-Lindau syndrome, we just have a look about your hemangioblastoma. See, this is how hemangioblastoma looks. There'll be both the stromal areas. These are my stromal areas, and obviously you can pick up lots of vessels. And as I said that these vessels are newly formed blood vessels, so you can see the hemorrhage also. The RBCs are spilled all over the stroma, right? Go back again, lots of stroma. It's not just the tumor happening in the blood vessels, the stroma also will increase. It's a blastomal tumor, both stroma will increase and my blood vessels also will increase, fine. Okay. Renal cell carcinoma, the clear cell variant. This is a very, very simple diagnosis. When I see clear cells, I'm going to call it renal cell carcinoma. At the same time, when I have clear cells in the kidney, renal cell carcinoma, I'm not going to call all the clear cell carcinoma as my von Hippel-Lindau syndrome. They might be sporadic also. So to prove it is not sporadic, I definitely need a genetic analysis in the germline. If I do a blood investigation and say that mutation is present here, most likely a congenital problem and not an acquired problem, right? Again, if we know the pathogenesis, I can extrapolate a few more things as well. So when one Hippel-Lindau syndrome was mutated, there is increased amount of erythropoietin, right? This is a feedback. There will be increased amount of RBC production. So if there's an increased amount of RBC production, am I right in saying that there will be polycythemia? Undoubtedly, right? So polycythemia here is considered as an paraneoplastic syndrome in renal cell carcinoma. You know what is paraneoplastic syndrome? It originates, it's seen in the cancer, but it's not due to the cell of origin. Now I have a kind of an difference of opinion. I just now said that it should not be from the cell of origin. If it's not from the cell of origin, kidney secretes erythropoietin. Polycythemia should be a symptom, not a paraneoplastic syndrome, right? The reason why I'm calling it a paraneoplastic syndrome is, Avinash said that erythropoietin is secreted by peritubular cells. But those peritubular cells didn't give rise to the cancer. What gave rise to the cancer? Proximal convoluted tubule cells, right? So this paraneoplastic syndrome, because it is not the erythropoietin, EP was not secreted by proximal convoluted tubule cells, which is the cell of origin. Because you might get a doubt later on why I'm calling it a paraneoplastic syndrome. It should be actually the symptom of the tumor. It is really a paraneoplastic syndrome only. Fine, got it? That's in short or maybe in detail about one Hippel-Lindau syndrome. We need to know about one Hippel-Lindau syndrome. As I said that these are the criteria laid down by WHO. If at all anything comes, it might help you. At 5 years of age, retinoscopy should start. At 5 years, because there is a very high risk. See, when I say 5 years, if it's a type 2C, retinal hemangioblastomas and retinal hemangiomas will not happen. So I can totally avoid this. Right? The patient need not be said that you will have a risk of retinal tumors. It's type 2C, right? MRI of CNS and abdomen should start from 10 years of age. Again, I can easily say that, okay, if it's not required, I'm going to skip that. When I don't have a CNS hemangioblastoma risk, I need not go with that. I can just go with the screening of abdomen alone, right? So this is how I screen the patient with VHL. Fine, done. Okay, that's was a deep discussion. Is there any doubt in one Hippel-Lindau syndrome? If not, we'll go to the rest and we'll finish it a little bit early. No doubts? I hope we are clear about one Hippel-Lindau syndrome. We won't have any further doubts in one Hippel-Lindau syndrome. Fine. Okay, great. Now let's move on to Li-Fraumeni syndrome. See, Li-Fraumeni syndrome is a very famous one. There was a question in JIPMER based on the criteria of Li-Fraumeni syndrome. I'll talk about the criteria as well because the criteria is a bit complicated. We have two groups called as Li-Fraumeni syndrome and Li-Fraumeni-like syndrome. Right? One thing we know about Li-Fraumeni syndrome that all of us know. Again, it's an autosomal dominant disorder. What is the gene mutated in Li-Fraumeni syndrome? That's a famous question. I'm sure you know the question answer as well. Li-Fraumeni syndrome has a gene mutation. Yeah, p53, right? The p53 gene is getting mutated in Li-Fraumeni syndrome. p53 is obviously a tumor suppressor gene. It's the most common gene mutated also, right? So the function of p53 is whenever a cell has mutation, whenever any cell has mutation, my cell should try to arrest the cell division, the multiplication. So what p53 does is it's a guardian angel of the genome. Whenever I have any mutation, p53 will stop the cell cycle and say that try to repair the defect. If you are not able to repair, kill the cell. That's the ideal role of p53. Again, we need to know about normal to understand abnormality. A normal p53, what it does is it's going to cause a cell cycle arrest in case of any mutation. It can be as trivial as an silent mutation. That also will stop. It will have a check mechanism, that's all. p53 can stop cell cycle at G1S, G2M, wherever it wants. As I said, that's guardian angel. It can stop at wherever it wants, right? So once it's going to stop at wherever it wants, it's going to have two mechanisms. It's going to repair the defect, like your methyl mismatch repair will be recruited or your nucleotide exchange repair will be recruited based on what damage it is. If it's not able to repair, if I can't repair it, what I'm going to do is I'm going to kill the cell. Kill the cell by apoptosis. Okay. This is what happens in p53. And I'm going to kill the cell by apoptosis if I'm not able to repair. So when I have a p53 loss of function mutation, because again it's a tumor suppressor gene, I'm right in saying that whenever I have a mutation, no one is there to stop me. So that mutation keeps on accumulating and is going to give rise to a cancer, right? So this is the mechanism by which p53 will cause cancer in a syndromic condition like Li-Fraumeni, or in a sporadic condition like anything. Like colonic cancer can have p53 which is sporadic, right? That also the same mechanism is going to cause. One thing I wanted to add here is, how do I interpret the IHC of p53? Because p53 IHC is very commonly available than the genetic analysis, is cheaper, that's all. So there comes a confusion. If I know p53 is due to loss of function mutation causing, tell me what should be there in IHC, the immunohistochemistry, positive or negative? What should happen to p53? Should be positive or negative? p53 should be negative, right? It's loss of function mutation, right? But when I say IHC, I have something called a mutant phenotype. I'll explain this mutant phenotype because quite a few students have asked this question, especially when you read this mutant phenotype of p53 in your ovarian cancers, right? Perfect. Right, Akash said that it should be negative. When I say negative, I'm sure that there is a risk of a mutation. I know that it's a mutant phenotype only, right? It should be completely negative. And one more reason, it can be completely and diffuse positive. See, when I have a diffuse positivity also, I call it a mutant phenotype only. We'll explain why diffuse positivity is also called as mutant phenotype, because this might be out of the box. Don't say if p53 is positive on IHC, it is not mutated, it's again mutated. Why in that scenarios? Am I right in saying p53 here, like I have a mutation coming inside, p53 will momentarily raise and then it will come down automatically? Yes, that's how what happens in p53, right? So if I have a mutation, let's say there's a functional mutation where p53 is destroyed, but functionally destroyed, but the protein accumulates and is not getting removed. That is a possibility, right? One, it's not at all formed. One, it is formed but not removed, but not functional, right? But these are accumulated non-functional p53. When it's diffusely positive, that cannot happen in a normal person. Like I said, in a normal person, p53 will be momentarily increased, that's all. Just a momentary increase, that's all. It's not throughout. So which means a normal p53 staining also you have to know, it will be positive, again it will be heterogeneously positive. Heterogeneous in the sense, if you have like 100 cells in the field, 3 or 4 might have positivity, because that point of time I have taken a biopsy, that point of momentary increase, rest everything will be negative, right? So when I say heterogeneous positivity on IHC, it is normal. IHC of p53 both complete negative and complete positive, diffuse positive, I'm going to call it positive only, fine? This you can use it for any p53 for any cancers, okay? I'll come to this tumor. So we know about Li-Fraumeni syndrome. We need to know about the criteria for Li-Fraumeni syndrome. See, as I said that we have two syndrome. One is a classical Li-Fraumeni syndrome, another one Li-Fraumeni-like syndrome called as LFL, right? I'll go to the criteria. So when I take Li-Fraumeni syndromes, I have a classical Li-Fraumeni syndrome. The other one is called as an LFL. It's a Li-Fraumeni-like syndrome. We will not go into the entire criteria for Li-Fraumeni-like syndrome, because there are 3 different criteria. There's something called an E2 criteria, P1 criteria, and your Crumpet criteria. Right? I'll just name the criteria. It's called a Li-Fraumeni-like syndrome E2 criteria, Li-Fraumeni-like syndrome B criteria. We'll not go into it. Just the name, if it comes, it might tell you. The Crumpet criteria is much more recent and is used in most places. At least remember the name, Crumpet criteria. Fine, this is for Li-Fraumeni-like syndrome, we'll ignore that. We look at the classical Li-Fraumeni syndrome criteria, fine, because this is what was asked once in JIPMER. So if at all it repeats in INI-CET, you should be able to answer it, fine. So I need the criteria used to identify the affected individual in the family, right? One, I should have sarcomas. Sarcoma is a classical finding seen in Li-Fraumeni syndrome at age less than 45. It could be any sarcoma, fine. Any sarcoma, when I have them in less than 45 years of age, because sarcoma is not a tumor which is going to come in a younger age group, right? Sarcoma in less than 45 years of age, I consider that as a positive criteria, fine. Okay. Second thing is, at least one first degree relative should have any tumor of Li-Fraumeni phenotype. I'll tell you what are the phenotype of Li-Fraumeni, again less than 45 years of age. A first degree relative can have any Li-Fraumeni tumor. I'll tell what do I mean by Li-Fraumeni tumor. It's not like any tumor less than 45 years of age. Fine. Okay. The third is I can have a second degree or a first degree relative with cancer or sarcoma, cancer of any cancer. Like when I say second degree relative less than 45 years of age, I'm okay with cancers. If it's a sarcoma, then I'm going to say in the second relative or any age, right? This either this or this required. A second degree relative, I have the Li-Fraumeni tumor less than 45 years of age, right? Or I can have a sarcoma in a second degree relative of any age. Okay. So this I'm going to consider as a Li-Fraumeni phenotype. This was the criteria used for Li-Fraumeni syndrome, so I have to know about this. So what do I mean by Li-Fraumeni tumor, right? So Li-Fraumeni has a very particular tumor phenotype. There are very classical tumor phenotype which will be seen in Li-Fraumeni syndrome. Like if I see this tumor, I'm going to think of Li-Fraumeni syndrome. I'm sure at least one tumor you will know when I say it's seen in p53 mutation. What tumor comes to your mind first when you say it's a p53 mutation? At least one of them will come to your mind. p53 mutation. One tumor which comes to on top of your head. Breast cancer, right? Breast cancer is related to p53 mutation, so that's one thing which will come to my top of my mind, right? When I say Li-Fraumeni tumor, I can have a breast cancer. Most likely, not always, these breast cancers will be triple negative breast cancer, one thing, right? Think of Li-Fraumeni. Second, soft tissue sarcoma. I'm writing in the order of decreased incidence. The commonest tumor in Li-Fraumeni phenotype is definitely your breast cancer only, fine? It's almost seen in 1/3 of the patients in Li-Fraumeni syndrome, fine? Next, CNS tumor. See, this combination is a bit unlikely. CNS tumors, I have lots of CNS tumor with skin manifestations. I don't have a link with CNS tumor and breast cancer. BRCA will not cause CNS tumor, right? When I have CNS tumor with breast cancer, I'm going to think of Li-Fraumeni. CNS tumor, soft tissue sarcoma, breast cancer, I'm going to think of Li-Fraumeni, fine? In CNS tumor also, not any CNS tumor, I can have an astrocytoma, glioblastoma, medulloblastoma, choroid plexus tumor, especially these four phenotypes only. Astrocytoma, I can have a medulloblastoma, I can have a glioblastoma, the most aggressive CNS tumor, and I can have a choroid plexus tumor. Only these four. If I have any of these four, so it has to be biopsy proven, it cannot be diagnosed on an imaging finding. Biopsy proven any of these four tumor, I'll say that okay, this is coming into Li-Fraumeni tumor. Less than 45 years, any of these tumor with other findings, I'm going to call this a patient with Li-Fraumeni syndrome, right? Next, adrenal gland. In adrenal gland, it's not pheochromocytoma, it's adrenal cortical carcinoma. Okay. And in bone, you have osteosarcoma. I'm writing OS for osteosarcoma and leukemias. Okay. Leukemias, I'm writing it lower down the cost because leukemias have, it's not very classical for my Li-Fraumeni. I can see in many other conditions because it's a very widely heterogeneous subtype, so I'm not going to consider that. I'll put that very down the road. Leukemias can be seen in 4 to 5%, so that's last. So when you have the first three, remember the first three: breast, CNS, soft tissue, less than 45 years of age. Any patient, think of Li-Fraumeni. Please do one molecular subtyping. You have to give it. It's not that syndromes are rare. It's that we are not looking for the syndromes. Syndromes are definitely not as rare as what we read. See, what your textbook will say is, I will see a Li-Fraumeni syndrome, 1 in, let's say, 5 lakh people. 1 in 5 lakh people is not rare in our country, considering our population, right? That's the thing. It might be very rare in USA or UK, where the entire population is only that much, right? So in our country, when I say 1 in 5 lakh, though it is extremely rare, 1 in 5 lakh, but we have 120 crore people. So 1 in 5 lakh will be easily coming to us. So I am missing those cases. So when I have these three combinations, less than 45 years of age, in any patient, please do the testing. I have to look for the microscopy, genetic counseling, do the testing for the offsprings also. It's required, it is must. Because I will have an idea about it, and in future, if I have something management, as of now I don't have anything to manage, at least when I have a breast cancer, early diagnosis, screen the patient for soft tissue sarcoma, early diagnosis prevented. CNS, unfortunately I can't do anything, you cannot remove part of the brain, but yes, when I have a tiny tumor in the, let's say, thigh muscle, excise the tumor before it becomes malignant and before it spreads. So you can have an early diagnosis, better management, right? So for all these things, you have to do one P53 mutation testing, Again, we are trying to subclassify P53 Li-Fraumeni syndrome also like my one Hippel-Lindau syndrome. So if I know the prognostic aspect, I can have a very good idea of what to screen and when to screen and tell the prognosis to the patient, right? So that's about Li-Fraumeni syndrome. The most important is criteria. You remember the 3 criteria of Li-Fraumeni like syndrome. I'm not going into that. It's not much required for us, right? Then we'll go to your. I want to discuss something about BTS, right? Because BTS is a new thing. Fine. I'll discuss about Cowden soon. We have something called a brain tumor polyposis syndrome. Okay. I'm sure you know this. When you have an familial adenomatous polyposis along with a brain tumor, what is the syndrome we used to call them as? We used to call them as Turcot syndrome, right? I am renaming Turcot syndrome. The entire pathogens of Turcot syndrome, everything, we are trying to change it. We are grouping them as brain tumor polyposis syndrome called as BTS, fine, BTP, right? So brain tumor polyposis syndrome has 2 subtypes. One of them is my BTP1, which is otherwise called as a mismatch repair syndrome. The other one, which we used to call as Turcot syndrome, which is again a variant of FAP. I'm not going to call it a Turcot syndrome anymore. I'm going to call it a BTP2, right? We'll call it a brain tumor polyposis syndrome 2. The older name was Turcot. WHO says stop using the term Turcot because the understanding of brain tumor polyposis has become more and above, fine? So when you see mismatch repair syndrome, what comes to your mind first is that HNPCC? Actually, it is not HNPCC. It's something different, very slight difference between HNPCC and this. I'll tell you the difference. HNPCC also mismatch repair only. But what happens in HNPCC is I'll have an heterozygous loss. But here I'm going to have both allele mutations is going to happen, right? So first we'll look at BTP1 and we'll look at BTP2 is almost like my APC beta catenin, your classical FAP only, right? The name has been changed and called as BTP2, fine? When I come to BTP1, brain tumor polyposis syndrome 1, it's an autosomal dominant syndrome inheritance, where it will have a reduced penetrance for sure, like any other autosomal dominant syndrome. I'm going to have biallelic mutation. That's very, very important. HNPC is not biallelic, HNPC is single, it's heterozygous, right? Here I'm going to have biallelic mutations, fine, in your either one of those. See, I have 4 mismatch repair genes, right? In any of your MLH1, PMS2, MSH2 and MSH6, right? I can have in any of these 4. I'll tell you why this understanding of BTP is required for me. See, let's say that I'm having a patient with colonic cancer, HNPCC. In HNPCC cancers, related cancers, brain cancer, CNS cancer is not a part. Endometrial cancer, colonic cancer is a predominant one, right? Brain cancer doesn't come, CNS cancer doesn't come, tumors doesn't come. But if I have a colonic cancer, the difference is that here I am having biallelic mutation. So this can be diagnosed only on genetic analysis. It cannot be diagnosed on an IHC. I'll tell why you doing a genetic analysis is required. Only when you have the knowledge of doing a genetic analysis, you will look for the syndrome. Otherwise, you're not going to look for the syndrome. Let's assume a person presents with a colon polyp, right? Colon cancer, because brain tumor polyposis, right? And you are having a colon cancer. The histopathology is suggestive of Lynch syndrome, right? It's suggestive of Lynch syndrome. And what we actually, as of now, do for Lynch syndrome is I'll do an IHC. When IHC is negative, I will call it, okay, suggestive of Lynch syndrome. Because when I say IHC negative, it doesn't mean it is biallelic loss. It is not expressing, that's all. So single allele loss also, functionality of will be lost. So I cannot say, if it's negative, there are 2 possibilities for me. It could be a Lynch syndrome, the classical Lynch syndrome, classic and HNPCC related one. Otherwise, it could be a BTP1 as well. The main difference here is CNS tumor. If I don't know BTP1 and I misdiagnose them as Lynch syndrome, I won't take an MRI brain. I might lose the patient having a glioblastoma, right? So if I know that, okay, I know its IHC is negative. So second thing what I have to do is, you have to do a genetic analysis. So genetic testing should be done not on the tumor, you have to do it on the blood, right? Of the blood, when you do it, again, genetic analysis will give me two possibilities. I'm having a heterozygous mutation, or I'm having a biallelic. Biallelic is homozygous mutation, right? And biallelic loss, which is homozygous. See, when you take HNPCC, it seems like your Knudsen's 2-hit hypothesis. That's also inherited only, right? So one hit is at birth. The second hit happens in the colon, or the second hit happens in the endometrium. So when you take a blood analysis, if it is HNPCC, I'll have only one hit, that is heterozygous, right? I'll have only one hit, this is HNPCC. But unfortunately, in a biallelic loss, this is my BTP1. So when I know it's BTP1, obviously my way of approach to the patient should totally change. I have to screen for my tumors in the CNS also, which we were not doing it in HNPCC, right? That's one major study, because BTP1, the glioblastoma occurrence is approximately at 18 years. 18 years having the one of the most aggressive brain tumor, I have to diagnose it beforehand, right? So that's one of the main problem in missing out BTP, because we say that I'm going to use Amsterdam criteria to say, okay, familial history is a Lynch syndrome. I'm totally disregarding BTP. You might be extremely happy in diagnosing Lynch syndrome, but I've forgot BTP. I might lose the kid of the patient if it's BTP. 18 years glioblastoma, right? The mean age of glioblastoma. You know about glioblastoma, it's a very, very aggressive tumor, right? And BTP is approximately 18 years. The normal age is around 50-60 years. 18 years a patient can have glioblastoma, should be evaluated. Early diagnosis, I can have a genetic counseling, and let's say if possible in future I may be able to treat the disease. Only when you diagnose something, I will know, okay, that actually exists, I have to treat the patient. If I don't do that, I cannot diagnose and I can't treat the patient, right? So this importance of discussing about BTP is to know the difference between my Lynch syndrome and my HNPCC. Do you have any doubt in BTPs? Because BTP must have been a new thing for you. If you have any difficulty in differentiating in HNPCC, your Lynch syndrome and your BTP1, let me know. I'll definitely talk about it again. Okay. If it's not, you can go to BTP2. See, BTP2 is simple. It's same FAP, familial adenomatous polyposis. The only thing is, the Turcot syndrome has been removed. The name Turcot syndrome, I'm removing it, disregarding it. I'm just going to call it BTP2. Fine. So the thing in BTP2 is you are going to have lots of colon tumors, like same like any HNPCC. In addition to that, I'll have your CNS tumor. Most likely the CNS tumor is going to be medulloblastoma, because WNT pathway is involved, which is going to be increasing medulloblastoma. Fine. So I see BTP2, or now it's FAP only. The term Turcot is being removed slowly. It's obsolete now. So hopefully in future we'll remove the entire term of Turcot syndrome. We're going to call it BTP2 only. Fine. Here I'm going to have more amount of colonic polyps. The colon polyps is more important for me here. I can have CNS tumors, but unlike it's not the first manifestation. My problem is mainly colon polyps, so that's more dangerous here than my CNS tumor. When it comes to CNS tumor, it's Turcot, right? So there'll be more as a result of medulloblastoma. Okay, just a second, I'll refresh it. Hello, hello. Is it fine now? Rishabh? Not fine yet. Is still like going? Okay, great, fine. Okay, so in addition to that, we'll have medulloblastomas as well. Fine. So that's BTP2 or Turcot syndrome. You should be knowing about it. Fine. So the main reason for going to BTP is the BTP1, which is not Lynch syndrome. It's a variant of, maybe like a variant of Lynch, which you have to be aware of. In future, if you encounter anything which is like Lynch, please do a germline mutation testing rather than just going for your tumor testing alone. Fine. The next thing what we're going to discuss about nevoid and basal cell carcinoma syndrome. It's otherwise called as Gorlin syndrome. Maybe in homework for you, we have two Gorlin syndrome. Tell me what is the other Gorlin syndrome. One syndrome is my nevoid basal cell carcinoma syndrome, Gorlin syndrome. This is also an autosomal dominant inheritance. Fine. Here I'm going to have a mutation in my PTCH. PTCH stands for your patch signaling pathway. PTCH has two types of PTCH. I'll have mutation in any of the subtypes. I'm going to call it patch signaling pathway, right? PTCH gene. Fine. PTCH gene is in chromosome 9. That's going to get mutated. See, when I come to nevoid basal carcinoma syndrome, I'm going to have two important things here. One, you will have cancers for sure. In addition to cancers, I'm going to have few embryological anomalies also. Because you have to understand about why I'm having embryological anomalies, I have to go and see what is PTCH actually doing. Right? So PTCH is involved in two things. One is cell proliferation, other one is obviously embryogenesis. That's the reason I'm having embryonic abnormalities. Right? First we'll look at what exactly a normal PTCH does. And then we'll look at if it is having a mutation, tumor suppressor gene mutation, what is going to happen in the syndromes. Right? When I say normal PTCH, I have PTCH. It's a transmembrane domain. It will be attached to one more person called as smoothened. SMO stands for smoothened. These are actually two different molecules. They'll be attached to each other on the cell surface. Fine. So you have a receptor here. The receptor is not having any growth factors stuck to it, so it's just normal. Fine. It's called a sonic hedgehog. It's called hedgehog before it looks like this. It will be multiple domains which is forming like a hedgehog, so it's called a sonic hedgehog pathway. Fine. So what happens here is the smoothen will normally be there. When it's attached, there will be no transcription of the factors, which means it's not activated. That's all. Fine. It's not activated. Let's say that if I'm having a growth factor in presence, which binds to my PTCH, once it binds to this sonic hedgehog in the PTCH, the smoothen will get dissociated. SMO stands for smoothen. It will be dissociated from PTCH. Once it is dissociated from PTCH, what happens is this will cause transcription of GLI1. GLI1 is one of the most important transcription factor. This GLI1 has multiple alterations. This is a transcription factor. I'm writing TR factor for transcription factor. This goes and acts on the nucleus by having lots and lots of changes in the nucleus. Fine. So what it does is, one thing is it helps in my embryogenesis. Embryogenesis especially of CNS. Fine. Second thing is it helps in my cell proliferation. Okay. This is what actually in the normal PTCH, and all these are called as a sonic hedgehog pathway. Okay. SHH stands for sonic hedgehog pathway, which abbreviation is also known, so you have to know about it. Fine. This is what happens actually in a sonic hedgehog pathway. So this is normal. So I'm right in saying that when PTCH is functional, it's going to hold SMO to it. It will not cause cellular proliferation. So I'm right in calling it as a tumor suppressor gene, right? So when PTCH is gone, like when it is attaching to the receptor, it's going to let it go, which means the functionality reduces and smoothen produces proliferation, right? So when we're having a mutation in PTCH, which is actually a tumor suppressor gene, I'm going to have it at loss of function mutation, right? So in other words, in a person who's having mutated PTCH, this is not present. Imagine like that. So I'm right in saying that smoothened is always active, even in the absence of PTCH, right? It's always active, even in the absence of growth factor. I don't want a growth factor here. It's always active when PTCH is gone. So definitely it's going to cause all the problems, right? It will cause error in embryogenesis. It's not that embryogenesis is becoming more active. Embryogenesis should be in a normal position. If it's giving signals at the place it should not give, so definitely I'll have abnormality in embryogenesis, right? So when I have PTCH loss, smoothened is overactive, always active, even the absence of growth factors. I'm writing GF for growth factor. This is going to cause defects. It will cause defects both in my skin, in my CNS, in many places. So one of the classical thing since we are discussing about neural tumors, the features of your nevoid basal carcinoma syndrome or my Gorlin syndrome, Akash is right, the other Gorlin syndrome is meant to be, right? So first thing is multiple basal cell carcinomas all over the body, right? As I said that it will cause problems in my errors in my embryogenesis as well, right? You will have macrocephaly, that's very common in PTCH related persons. Again, it's though I don't call it an error in embryogenesis, but the normal formation is defective. So you'll have lots of palmar and plantar diskeratotic cysts and McPits, right? Palmar and plantar diskeratotic pits. It's not forming it normally, that's all. So that's also like an error in formation, though I don't call it embryogenesis. It's an error in the formation, right? So macrocephaly and my diskeratotic pits are error in formation. In addition to that, I'll have CNS tumors also. See, we read about one skin tumor, two problems in the formation, and CNS tumor is medulloblastoma again. So medulloblastoma has multiple subtypes. One of them is P53 mutated, one of them is SHH mutated, which is sonic HR pathway, which is PTCH related, right? So this is also possible in this, right? So all these, when I have all these features, I'm going to think of a sonic HR mutation. Apart from that, you can have multiple other tumors as well, but these are the ones which are more commonly seen, right? Again, as I said that these are not rare, these are common, we are not diagnosing it. WHO says that the incidence of Gorlin syndrome in USA is 1 in a lakh. That's 1 in a lakh. Let's say keep in India, it's a bit rarer there. We'll keep 1 in 5 lakhs. Still, it's very common in our country. We are not diagnosing it, right? So when you look at one medulloblastoma, so you have to know the entire spectrum. Like ovarian fibroma can also have this. You can have facial abnormalities, skeletal abnormalities, desmoplastic fibromas. When you think of one, look and examine the patient thoroughly. You might pick up these cases. The only advantage of picking up these cases, see, you'll have a better approach. That's all. You can tell the patients, family, see, there's a risk in the offspring. Let's go and see what I can do with that. As on date, with the genetic advancements what I have, if I know any cancer syndromes before giving birth to a kid, I can make sure the couple can give birth to a kid without that cancer syndrome. We can choose the embryos. Genetically, we can choose the embryos as on date. So these syndromes should definitely not be present to the next generation. So that's a role of a doctor. For that, I have to know these, I have to identify these, right? We can identify this. If we can identify, we can easily understand about it. Just go a little bit and see about my basal carcinoma. Then maybe last one syndrome, then we'll call it a day. Fine. So basal carcinoma, I'm sure you know it's more common in the facial area. In a derma, they'll tell exactly which location is common. There's one unique thing about basal cell carcinoma, right? Basal cell carcinoma is a syndrome which is a cancer which metastasizes or which doesn't metastasize. That's one unique thing in basal carcinoma. Basal carcinoma does not metastasize, right? So it's rarely metastasized, right? It's a one with very rare cause of metastasis, right? Let's see why it is not having metastasis very soon. So microscopy also, you know about basal carcinoma. What I'm going to have is, I'll have nests of basal epithelium. You have nests of basal cells. The basal cell will be extremely hyperchromatic. They are tiny cells in the dermis. This nest of basal cells is covered by collagen, dense collagen. This again, it's not something abnormal. Normally also my basal cell of epidermis lies on the collagen only, the basement membrane, collagen. So when it goes down, it takes the collagen along with it. So it's going to be like this. I'll have tumor cells with a thick surrounding collagen and basal cells are elongated. The other finding what I'm going to see in basal carcinoma is what I'm drawing here. The palisading appearance. The center I'll have tumor cells here, but when it comes to the corner you'll have something called as palisaded appearance, which is all the tumor cells will be parallel to each other. Parallel is palisading, and this is a true palisading, because why I call it true palisading is normal basal cells also will palisade. Obviously basal cell tumor also will palisade, right? So it'll have a palisaded appearance. That's also a characteristic finding. Now we'll come to why it doesn't undergo metastasis. It's simple. So I'm having a tumor which has a superb layer of thick collagen outside it. So do you think they can break this collagen and come outside? They can't, right? So they go in nests. They won't spread. It's very difficult for it to spread, but they can locally have an expansion, but it will not have a distant metastasis, right? So one more thing here is that this collagen might retract from epithelium, so that is also possible. Have something called a retraction artifact. So I'll put it as a third finding. It might be useful for an MCQ, but not for image-based understanding. It might be difficult for undergraduates to pick up retraction artifact, but nests of basal cells, blue cells in the dermis with peripheral parasitic diagnostic of basal carcinoma. I don't want any IHC for that. I can go ahead and directly diagnose basal carcinoma, right? Okay. I did have an image, just a second. Okay, this is basal carcinoma. You can see that the tumor cells are in nests. So when I say nest, it need not be just round. It can be like this. It can be like this, anything. The only thing is it's covered. It's covered by collagen. That's the most important thing here. And nests of blue color cells. These are the nests of basal cells. It's definitely in the dermis here because the epidermis is not seen here. It has to be in the dermis, right? Anywhere I can have seen the dermis. Peripheral parasitic might not be so much appreciated here. I might share you one more image where you can see the peripheral parasitic for sure, right? So that's the thing about basal carcinoma, right? The last syndrome, whatever we want to discuss here is, again, this is a unique thing, a recent one, so you have to look at this because most of the oncologists, oncosurgeons, and even medical oncologists, they are looking for this rhabdoid tumors in detail. We have something called as an INI deficient tumor that comes under the rhabdoid tumor, right? So this has a very bad prognosis, and for anything which I'm not able to diagnose, now I put an INI marker. IC is available that an practicing physician also knows. So if they are going to set questions, this might come, right? Whereas rhabdoid tumor predisposition syndrome. Just 5 minutes. Okay. So is there rhabdoid tumor predisposition syndrome? We did read yesterday about schwannomatosis. That we read about SMARC-B1, right? The SMARC-B1 is the INI deficiency. So we're having two types of rhabdoid tumor predisposition syndrome called as RTPS, rhabdoid tumor predisposition syndrome type 1, and RTPS type 2. Again, RTPS is a known abbreviation, you have to know it. RTPS type 1 is definitely more common than RTPS type 2, and here I'm going to have a germline loss of my SMARC B1. It's relatively rare. Here I'm going to have an germline mutation of one more SMARC group of thing. It's SMARC A4, right? SMARC is a group of protein, and here the A4 mutation. B1 is more common. B1 is INA as well. So what we read in schwannomatosis was the same thing. Then what makes schwannomatosis, what we read yesterday, different from this is, in schwannomatosis we said that it's involving neurofibromatosis also, NF2. That was the 4-hit pathogenic model. Here is not the 4-hit. It's typical like any other tumor suppressor gene. I'm going to have a mutation in this, so that will increase the risk of malignancy. That's all, right? Okay, just increase the risk of malignancy. These are termed as an INI deficient tumors. Okay, you have to know about INI deficient tumors. That's very important. As I said, that there is an emerging entity and they have one of the worst prognosis. I have not gone into the syndromic diagnosis yet, but INI deficient tumors are relatively common, so you have to know about it, right? So when you go to the SMARC group of tumors, again, as I said, it can involve many things. The diagnostic criteria obviously is only one thing. When you have multiple rhabdoid tumors in the children or in any of the family members, do a germline testing. That's all. I don't have I have to say this family member is nothing. Any INI deficient tumor, if it's multiple, do for a germline testing. Only when you do a germline mutation testing, you can identify them as of now. I don't have a criteria like first degree relative, second degree relative. You have to do a germline mutation testing. If it is there, I'm going to say it's seen there, fine. So what type of tumors are called as INI deficient? This thing is the list of tumors. The first thing I'm going to look for is in CNS. See, I call them rhabdoid, right? So when I call it rhabdoid, rhabdo means your striated muscle. So oid means like. So rhabdoid tumors will have an abundant pink cytoplasm. any high-grade tumor with lots of pink cytoplasm, which is reminding me of a skeletal muscle. Skeletal muscle have an abundant pink cytoplasm, or striated muscle. I'm going to call it a rhabdoid tumor. That's the first thing you have to look for. When it comes to CNS nerve involvement, there is a tumor called as an ATRT, atypical teratoid rhabdoid tumor. Fine, it's teratoid rhabdoid tumor. You can think of your rhabdoid inherited rhabdoid syndrome. Fine, rhabdoid tumors are ATRT is common in CNS only. Fine, this is common in your children. Like I said, that children are more importantly affected, so I need to have much more clarity in diagnosis. With more diagnosis, more cases, maybe in future I'll be able to find a drug to stop these tumors, right? I can have any tumors, but the common one is what I'm going to say, my ATRT. Meningiomas can be there. I can have many other tumors, or any tumors with rhabdoid morphology, I'm going to look for it, fine. Extra CNS, I can have rhabdoid tumors in kidney. It's possible. I just need rhabdoid tumors. I can have it in your GIT. It's possible. Head and neck, mediastinum. These are few areas where they are more common. That's all. Doesn't mean that it's limited only to these organ systems. Can have anywhere I have organ system and atypical rhabdoid morphology in an younger age group. I'm going to evaluate for the genetic analysis. If it is there, let's go and diagnose it. Hopefully, as of now, we can't do anything. The only thing I can say is we're going to lose the patient. That's all. I can prevent them, like I said, with genetic analysis. I can prevent them with the future offspring, but I can't treat anyone known if they are affected by it. Fine. Hopefully, in future, we'll be able to come to a conclusion. This might be important, remember that. And I have something called as INI deficient phenotype, remember that. And this is a new emerging entity. If at all it comes in an MCQ for you, you should share it. Fine. Okay. So I didn't read about, we didn't read about Cowden syndrome. Maybe we'll look at Cowden syndrome and other P10 associated tumors in a separate class of colonic tumors, colonic cancer syndromes. All these are CNS related cancer syndromes. So what we have done in the last 2 days is, I know this is an exhaustive session, but I did want to take time and discuss about syndromes, which familial tumor syndromes, especially related to CNS. Because whenever we come to anywhere, we won't get time enough to discuss in detail about these syndromes. We know something about NF2, pathogens we were a little bit lacking, so we went ahead and did yesterday about NF1, NF2, schwannomatosis, which is a new one for us, right? We did go with your one Hippel-Lindau syndrome today. Tuberous sclerosis we binded up yesterday, right? We did about Li-Fraumeni. Cowden we didn't do. Maybe I'll do along this with colonic syndromes, because colon syndromes are also important for an MCQs. You have Cowden, you have many PTP hematomata syndrome, my HNPC, my FAP, all of these syndromes are also important. We did see about Turcotte, nevoid basal cell carcinoma, and rhabdoid predisposition syndrome, right? Those are the syndromes which we're going to discuss today. If you have any doubts, any point of time, I want you to listen to both these videos once you're done with the routine, because these are, maybe it will help you to fetch the higher one. I don't want you to look at these videos and remember this and read this and memorize this without doing the routine. See, because routine will help you to sail through your 70-80% of the normal thing. Once you reach the 70-80%, which will give you a good rank, to come to the top, you might need to know these rare things. Fine. It's not the first thing to read. Definitely, it might be required for you for a higher one. Okay. Thank you for your time. Any doubt you have, you can ping me on Instagram or Telegram. We are having every day 10 o'clock Telegram quiz. You can come to this channel, Pathology by Dr Ranjith AR. It's an open group, an open channel. Once you enter that, you'll have image-based questions, and I'll tell you what to read by 5 p.m. yesterday, or most of the days, if you don't have other classes. Today we'll have a class at 9 p.m. in the Unacademy channel. It'll be a free live class, and you can we'll look at few MCQs, maybe based on these symptoms, so that we can wrap it up. Fine. Thank you for your time. See you soon. Till then, bye bye.